Welcome. I'm Dr. Kristen Eckstrand, a fourth-year medical student at the Vanderbilt University Medical Center and co-director of the Vanderbilt Program for LGBTI Health. I'm here today with Dr. Jamie Feldman, Associate Professor in the Department of Family Medicine and Community Health and faculty in the Program of Human Sexuality at the University of Minnesota. Dr. Feldman, thank you for being with us today.
My pleasure.
Start off with just a question. How are resilience and coping important for LGBT individuals across the lifespan?
Resilience and coping are really important mechanisms for LGBT individuals in maintaining and improving health across all elements of the lifespan, particularly early on. The mechanisms involved and those elements of resilience and coping differ for L, G, B, and T individuals. So the elements that are involved for each of those individuals differ. For example, transgender individuals may benefit, the elements that are involved in transition, for example, are really crucial for resilience and coping, while the coming out process may be of key importance for lesbian and gay individuals. And we're still learning about what those elements are. So it's really hard to lump what are those key factors for each of those groups. And while the general terms resilience and coping are important, you need to look more deeply and more specifically for each of those groups.
And so in the context of a clinical encounter, when you're working with someone who identifies in one of the populations that you mentioned, what strategies can be used to foster resilience and the development of healthy coping mechanisms?
So you need to really look at the individual, find out what their support systems are, where they are in the process of their sexual orientation or gender identity, where they are in community support, peer support, family support systems, economic support systems, their own identity formation, economic resilience, and getting to know that person as an individual and what they have to draw on, and what the lack of coping strategies that they may have. These are all parts of the larger concept of minority stress that isn't limited to LGBT, but any minority group in the U.S.
Could you explain a little bit more about that concept of minority stress?
So minority stress really talks about when you are a member of a minority group of any minority group, not just LGBT, but any minority group in the larger dominant culture and sociologic culture of a dominant society, you may feel a variety of stressors or experience a variety of stressors that may include stigma, economic barriers, social barriers, and these create stressors that affect health in a variety of ways, and that increase risk factors for health, unsafe behaviors, and increase risk for things like cardiovascular disease or alcohol or substance use. And that's what we call the minority stress factor. In a sense, the world is unfair. There may be stigma, and that adds another risk as opposed to just the usual risk factors that all of us may face, whether a part of a minority or not.
Okay. And within the LGBT context, are there certain factors within that minority stress model that are important to ask about in the clinical encounter?
Mm-hmm. So stigma is one of the larger ones. Are people experiencing stigma? Are they anticipating stigma? So they may not have been experiencing stigma in their life, but they may be anticipating that they will find it in medical encounters, for example, encounters with medical personnel, not just the physician themselves, but the front desk, insurance companies, nursing staff, the broader medical or healthcare system, such as emergency rooms. Are they experiencing stigma in job opportunities within their family? Are they anticipating that life is going to be harder, more difficult. Those are things that anticipating stigma can do. So just the anticipation that they're going to have a more difficult life or people are going to judge or cause them difficulties will be a problem. The experience of stigma certainly is a large factor. And then, again, in job opportunities, encounters with other social figures, whether that's law enforcement, again, medicine, education.
So you've identified a number of different factors that, again, can lead to the situation of an individual needing to have certain aspects of resilience to lead a productive and successful and fulfilling life. Are there any validated screening tools that providers can use to sort of pull out individuals who may be having maladaptive coping? Are there any screening tools like that?
I don't know that there are validated screening tools that identify resilience and coping mechanisms that are specific to LGBT populations. And I don't believe that there are ones that, you may find ones that are specific to other minority groups. I think we're working on those things. We may be working on those that are identifying specific resilience factors. That work is definitely proceeding. I certainly know that there's work certainly in the transgender population that are identifying resiliency factors, particularly with regards to stage of transition. So it's a work in progress, but I don't think we have really good validated measures just yet.
Maybe just to clarify a little bit more, when you talk about stage of transition, what are some of the different stages of transition and what might you look for within an individual in terms of how they are coping with that?
Okay. So among the transgender population, patients may be gender questioning, trying to understand whether indeed their gender corresponds to the gender assigned at birth, and whether they're experiencing dysphoria or discomfort with that discrepancy, and putting a name to that feeling, what they're going to do with that feeling, and how they want to approach that, whether they're going to seek medical attention for that, peer support, whether they're going to reveal that discomfort to others, whether they're going to make any transitions socially or medically, and then how far along that transition line, whether socially or medically, they are going, hormones, surgery, et cetera. And then from a timeline out there, how long along that timeline are they living in that, their transition selves. And there is very good research so far to show that there are different stages of risk associated with that stage of or transition. For when people, for example, the TransPulse study in Ontario has identified a very high level of risk and suicidality associated with as people just start to transition. So just before they start to make any social transitions or medical transitions, as they're kind of on that cusp of transitioning, that's when risk can be very, very high. Work here at the University of Minnesota, for example, has identified in one study that as people are further out in their transition selves, whatever that transition looks like, doesn't necessarily mean one particular pathway or another, that risk, particularly for HIV risk behaviors, tends to decrease, at least among trans women. And so clearly, that's something very specific to the transgender community, and that I think is very important research that we need to look at. And how can we intervene to keep those risks, manage those risks, and help people through them?
Yeah, I think that last part is very important about intervening. You'd mentioned before about the minority stress model being associated with maladaptive negative health outcomes such as cardiovascular disease. So when you identify that someone may be engaging in negative coping mechanism or need to have some increase in resilience, what strategies are out there to help reduce harm for LGBT individuals who may be engaging in a high-risk coping behavior?
This, in a sense, is the fundamentals of family medicine, and it's it's true whether you're dealing with an LGBT population or any population, is first working with the patient to see if your patient recognizes that these are problematic areas for them, or that they're unsafe, or that they are causing a risk. At the same time, what purpose do they serve for them? For example, smoking is a wonderful one, because people are often recognizing that smoking is harmful, and at the same time, when you talk to people about it, smoking serves a purpose for many, many patients, LGBT or otherwise, that it serves a purpose in our lives, reduces anxiety, relieves stress, and you have to be able to replace that. You can't just take it away. Yeah. And the trick with any population, and then getting down to kind of the nitty-gritty with an LGBT population, is finding a mechanism that makes that either harm reduction or replaces that with something that serves that same purpose.
Yeah, and in your response, I hear you essentially mentioning recognizing what that coping mechanism does for someone, how it actually is supportive of them. So that's a relatively non-judgmental and compassionate response. What other responses do you think non-judgmental and sensitive are important, maybe particularly for transgender individuals to hear when they might be engaging in a high-risk coping behavior or otherwise?
Okay. So other things is to recognize that minority stress exists. I will often use the term that the recognition that life is unfair. Okay, and how is life unfair for you? What stresses are you experiencing? Where are you in trying to achieve your goals? Where is the push and pull in one's life? And how can I assist you in making that a little bit easier? I can't make life not unfair, because I don't have that major power. Okay, we can all work toward that, but in a one-on-one conversation with a patient, I can't make life not unfair. So how can we, as a dyad, patient and physician, help move the patient's agenda forward to make them be able to cope better and give them a little bit more tools in the toolbox? So that may be, how can we move transition forward? How can we reduce and then pull back on that behavior as transition moves forward? So simultaneous kind of work.
I'm curious about, so again, building that patient-provider relationship in order to actually address someone's health is a bit of a challenge, particularly in the beginning when you're building that trust. Can you talk to me a little bit more about how you build trust with an LGBT or transgender patient who may be coming into your office with this certain amount of assumptions that this is going to be a scary thing. Yeah.
So the first thing is being really open and honest about where you are as a provider, and acknowledge that you are going to make mistakes and apologize right away when you do, and be a partner, and then find out where your patient is at, and then work together in establishing that partnership. Meet often, and find out what they want from you and whether you can provide that. For example, if a patient wants certain things that I can't provide, say they're looking, they want surgery. I'm not a surgeon, so I can't. Well, how can I help you find a surgeon? So be honest about what you can provide and facilitate what they need fairly early on, and have a good partnering discussion, I think, is the key. Honesty, working on sort of what the patient's needs and agenda are without losing sight of who you are and what you can provide, and being very honest and upfront about that, I think is very key. So nobody's anything other than authentic in who they are, I think is the key. And being ready to apologize, or being ready to acknowledge one's mistakes, okay? So that everybody understands no one's perfect, that we're all learners.
Yeah. And so I think that frames very nicely sort of the patient provider relationship. And so once someone has identified that they may be engaging in a behavior that is a negative coping strategy that they would like to change, and they say, this is what I'd like to work on. When you think about whether that might be substance rehabilitation or smoking cessation, are there any LGBT population specific programs that address high-risk behaviors, and do you find them to be valuable and effective?
Absolutely, particularly for substance. Having population-specific, and particularly for LGBT-specific, and I know certainly for trans-specific patients, this is can be very important. I know in the Twin Cities area, Pride does a great job with substance and addiction, the addiction piece. They treat LGBT populations. Our transgender populations tend to do fairly well in that group, although sometimes, again, that fit between LGB and T doesn't always mesh really well, because sexual orientation and gender identity are not, the issues are not in the same kind of boat, because we're dealing with a population that deals with hormones, surgeries. The idea of who I am is not what my body was assigned as opposed to whom I love and am attracted to. And those are very fundamentally different questions. They intersect a lot, but the challenges that those populations meet and it can be quite different. And so sometimes they need different groups to deal with what kind of stressors they get to when you deal with a substance program. But I think when you deal with that type of minority stress, when you deal with that kind of stigma, it's really important that, particularly for things like substance abuse, safer sex issues, HIV issues, those become really important to have groups that are specific or treatment programs that are specific. Certain mental health issues also become more benefit from approaches such as inpatient psych treatment, I think also really are helpful. When you get to things like significant psychoses, that's a little harder to try and break down. Housing, again, very helpful if you can get it down to that level. Law enforcement, again, down to that level. Certain other issues may be less likely to try and break down, but the more you can get it nailed to the specific population, the better.
Yeah, and it sounds like as a provider, you in Minnesota are pretty aware of what community resources are available to the patients that you see, and you do a great job of listening as to whether a certain program is good for addressing sexual orientation or gender identity, and listening to patient feedback, which I think is great. In terms of health messaging strategies to promote health, are there any specific strategies or things that you find to be more effective working with LGBT populations in terms of promoting sort of population level health for LGBT individuals?
This is what I do when I try and train my residents too, and it works really well for patients. We usually think of the guy complete physical, this is what we need to do for men to maintain, this is men's health and this is women's health, and you need to get your... I threw that out a long time ago. Rather than having a male complete physical annual exam and a female, we do go by organ systems present rather than this is the guy's annual exam and the women's annual exam, because it turns out that not every guy has a prostate and not every woman has a breast and not every woman has a uterus, because Lord knows we have a ton of hysterectomies in this world and a lot of prostate surgeries in this world. So I kind of threw that out and said, if you've got a body part, it needs to be taken care of. And that's just kind of, and since Americans are kind of fond of their cars, it's sort of like a car. If you've got a carburetor, you need to tune your carburetor or whatever it is. So when I approach, and this particularly works for trans patients, but not limited to it. You have a body part. It needs to be taken care of and needs to be maintained. Here's the health maintenance schedule on that body part. Here are the challenges in meeting that health maintenance schedule that you might experience due to a variety of reasons. Because of hormone use, this is true for my cisgendered patients as well, your health maintenance schedule may change. How would you like to approach that health maintenance schedule? If you can't meet that health maintenance schedule, here are your options that we can do to address that.
And you used a term in that last sentence, cisgender. Can you explain what that means?
Okay. So cisgendered is kind of the hot term and taken from geometry, I guess, or algebra. Trans, or chemistry. Trans means opposite or alternate. Cis means the same, so body matches identity. Cis, same. So male, let's say male or masculine identified person with a masculine looking body, born or assigned at birth. So if I was assigned masculine at birth, everything looks to be masculine, and I have a masculine identity, that would be cisgendered masculine person. Trans, masculine looking body at birth, but feminine identity, trans person. Okay.
Thank you for that. And one other quick question for you here. You mentioned that some of the work that you did with students and residents about teaching health promotion. Are there any other opportunities for integrating LGBT health promotion themes into medical schools?
Oh, there are tons of opportunities. The trick is, one, making the time against lots of competing interests, because there's so much about medicine that we have to try and fit in. So is figuring out how that fits into one's medical school structure. But the best way is to incorporate that as part of the routine, okay? So if it's, just as we talk about when we teach how to do a physical exam, if you teach how to do physical exam, let's say we're doing a breast exam, and you say, you want a circular motion here, and you want to look for lumps, bumps, and things, and we're talking about people of color. You might say in skin of color, or in women of color, you want to look for X, Y, and Z when you do a breast exam. In lesbian women, you might want to look for X, Y, and Z. Now, in a trans man, if you're doing a chest wall exam, so you would incorporate that in the nature of doing things just as is, rather than making a special course that people have to remember the one time they took it. Okay? So it should be integrated throughout, ideally. At the same time, there are certain things that are specific to one's experience. For example, at the University of Minnesota, again, we have a human sexuality course, and in order to really kind of meet a critical mass of transgender people, because they may not meet them in their community, we have a panel, and people get a chance to, medical students get a chance to ask questions about trans issues with a group of trans people who are very willing to give of their time and energy and emotion to really talk about that with our medical students, and that's important too.
One other thing I noticed was when you were talking about the breast exam, you changed terminology from breast exam to chest wall exam when you were talking about the population that you were screening. Can you describe that, why you did that a little bit more?
So for trans men, most trans men will undergo chest surgery where the vast majority of breast tissue is removed. And so the recommendation from most providers is they still undergo a periodic, how often is still under discussion, exam of their chest wall, because there is some breast tissue there. And so periodic chest wall exam, because there's no breast per se. And so they would have a chest wall exam to make sure that, especially over the age of 50, and make sure there's no lumps, bumps, or anything growing, and education about the remote but possible risk of breast cancer as they age.
And if a trans man doesn't have surgery, would you still use the term chest wall exam? Or
I might say chest exam.
chest exam.
It depends on, again, trans masculine people have various ways of identifying with their chests. Some may very well have a good relationship with their breast tissue and be okay with the term breast exam.
So using the term that the patient feels is appropriate for their body is
Yeah.
an important thing.
Is an important thing.
Dr. Feldman, thank you so much for being with us today. I really appreciate it.
Welcome.